So we made it. A few little technical challenges, but we did it. So tonight we're going to, am I on that camera?
Yeah.
That camera's on me?
Yeah.
Is it on there too?
Yes.
Oh, cool.
We got everybody.
Okay, so it's like this. So if I walk over here, then
Don't go to your right. You can go to your left.
so if I go over here, I'm more on the camera. Is it better?
No matter where, you're fully on the camera. Just
Okay.
don't go past the podium on the right.
All right. Man, you want to do that once they say don't do it, don't you? There's some people who they say don't go to the right. You just want to try a little. Okay, so tonight we're going to talk about migraines a little bit and go through it. It's actually kind of really pretty emotional for me. Just because I think migraines are really extremely emotional. And so if people have questions as we go, it's okay. Just so you know, and I'll show it again later, but a lot of what we're going to use is going to be from this book called Migraine Art, The Experience from Within. And so it's a pretty amazing book. Migraines are very different, I think, than other forms of pain. So other forms of pain don't have the same experiences that migraines have. Like plantar fasciitis just doesn't have the same experience that a migraine has. And there are these migraine art competitions where they are doing their migraine art, and it's pretty emotional art. Some of the images are a little bit shocking. I tried to not use too many of those, but some are a little bit shocking. So let's see how we go here. Oh, okay. So it says one aspect of the migraine experiences is that, am I able to have the other thing here? Is that possible? No? That's okay, yeah. So one aspect of the migraine experience is that it's rarely covered in scientific literature. So the effect of headaches have on work, family, leisure, and activities. As Wallace poignantly stated, migraines are an unsocial malady, often because it cruelly debars the sufferer from moving in society and enjoying family and friendly intercourse. A pertinent description of these social consequences can be found in a report by this novelist, Pamela Johnson, the Snow Lady, during a migraine symposium, when she suggested sufferers will try to conceal and deny an attack because of its effect upon others. When one has been suffering from migraine for a long time and has observed the effect on husband and child and friends, one knows that one is going to be a nuisance to them, however sympathetic they may be. A maddening thing is that whenever you have something important to do, or whenever there is something to which you are particularly looking forward to, migraine may most likely rob you of the capacity to carry out your tasks. And so what happens for people in these situations is they get this life-inhibiting experience that will separate them from the world or from going out and from doing things. And this book goes through, and you're really seeing the artwork of the people, but they're painting their experiences, and then they're talking about them. And it's just pretty intense, particularly if you have any type of personal experiences with it. So tonight, we're going to look first at what is pain, and then we'll look at some of the causes of pain, and then we'll look at some things related to neurophysiologically, what inhibits pain, and then how do we at Georgia Chiropractic Neurology work to help people with pain. Then we're going to move into a slightly separate thing of what is a migraine, what are treatments for migraines, and then what do we do for migraines. So we have to look at what is pain and what are the causes of pain. And interestingly enough, according to the International Association for the Study of Pain, they define it. And they say pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So pain is actually an unpleasant emotional experience, and we'll look at it, but there's no single stimulation that all people perceive as pain. There's not really nerves for pain. We talk about pain receptors, but they're actually nociceptors. So I think that they'll list this in here. So they list 6 key notes related to pain. So pain is always a personal experience, and it's influenced to varied degrees by biological, psychological, and social factors. So the person's experience of pain has a physicality to it, but it has also a psychology to it, and it has social interactions. It's not this simple linear thing, like you're experiencing this mechanical activity that we call pain. That's not it. It's biological, psychosocial, and emotional, okay? Pain and nociception are different phenomenon. So there's sensors in your body that we call nociceptors, and they measure tissue damage, but pain and nociception are separate. They're not one-to-one. So people can have enormous amounts of pain, but little to no tissue damage. And when they go to see doctors, the doctor can't really measure the tissue damage to say, oh, well, you have this much tissue damage, so you have this much pain. They're not equivalents. And some people have a lot of tissue damage, like some person can have their arm severed off. They could just pick it up, walk to the hospital, and say, hey, I need help. And they can actually interact with it totally different. So pain cannot be inferred solely from the activity of sensory neurons. Through their experiences, individuals learn the concept of pain. So again, you actually are learning what pain is through your life experiences. I always kind of like to watch the little kid. He runs and he falls down, and then the one parent reacts to it a certain way. He goes, oh, yay, look at that. And the kid jumps up and they go, yay. But another time the child falls down and they cry, and the person is very concerned about their child and shakes, and and you'll watch them, they'll stop crying. You ever seen it, by the way? Do you ever watch this? They stop crying, and then they kind of look around a minute, and the parent's still really worried about them, and then they start to cry again. Okay? So individuals actually learn their concepts of pain from their experiences in life. And if you're raising a child, you might want to think about that your perception of pain and your concept of pain, you maybe can teach your kid to deal with it a little bit better, perhaps, than you did. You can make an improvement for your kid and how they're going to learn to respond to pain. I think that's one of the things with sports is so good, or intense exercise, and you kind of embrace the pain, right? A person's report of an experience as pain should be respected. And this is really, really important for doctors, because a lot of times, and other family members, a lot of times individuals will minimize the other person's experience of pain. Like, hey, that's just what it is. Deal with it. It's really not that bad. It's a paper cut. What's your problem? But you have to respect the person's experience of pain. Although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. So we need pain. Pain's important. You have to experience the fact that something might be dangerous, and you might need to avoid it. So it's important to have that adaptive role of reacting to your environment, but it can lead to all of these other psychosocial challenges for people. And verbal descriptions is only one of the several behaviors to express pain. An inability to communicate does not negate the possibility that the human or non-human animal experiences pain. So people come in all the time, they can't really explain what they're feeling. It's like, what are you experiencing? And they're going, it's like this thing everywhere that's killing me. And it's like, well, what is the thing? And the person can't explain it. So you can't look at that. And that's what's so amazing about the migraine art, is that they're expressing their experience of suffering, but not just with words. They're expressing it with pictures. And to really understand those pictures is pretty amazing. So pain is always a personal experience influenced by varying degrees of biological, psychosocial, and social factors. And through life experiences, people learn to deal with pain. Now, if you look at a textbook, we'll say, oh, well, there's types of pain, you see, but that's really more nociception. And there's different types. And at GCNC, we try to understand all those, and we try to listen to the person and then help to figure out which one or more than one that the person's having. So there's neurogenic pain, which could be a peripheral nerve or a central nerve. There's myotogenous pain, which is really there's no nerve sensors in muscles. It's really around the fascia. So I'm a founding member of the Fascial Research Congress, and for the Fascia Congress, these types of ideas are difficult because we now have evolved and we understand that the nerve's not really in the muscle. Like this muscle is not a muscle. The bicep's not a muscle. The bicep has nerves in it. It has blood vessels in it. It has fascia in it. It has lymphatics in it. It has septums in it. It has all these different fluids in it. But you look at it and you say it's a bicep, but it's really more than that. So, but there's myotogenous pains, and we'll talk about that. Sclerotogenous pains are like from your joint capsules. So as chiropractors, which all the doctors here are currently all chiropractors, we really excel at sclerotogenous types of pain related to joint. Then you have visceral pain. So we understand that if something happens to someone's heart, they can feel pain down their arm. And then there's central pain patterns. I think the classic for that, number one, is migraines, but better to understand is maybe phantom limb pains, where the person doesn't have the limb, but they have the pain. Well, a lot of people have pain, like in their head, but it's not actually coming from the tissues of their head. And you'll see that a lot of times we try to treat the tissues of the head with Botox injections or steroids and things like that to try to help. But the reality is, particularly with migraines, they're central pains. And then there's different nerves. There's nerves that are related to measuring temperature and pressure. And then silent nociceptors come from your organs. So we're actually just going to look at each of these, and we'll take a look at how it goes. So what we have here is we have a receptor. So that could be a temperature receptor or a pressure receptor or different movement receptors. And they go through your spinal cord and they go up to your brain. And along the way, they go to your brain stem. This one here is very important. This is called your limbic brain. So this is your emotional system. So as information comes in, it travels up these pathways, and there's different types of information. So one is the newer pain pathway. And what it does is let's see if this video will play. Here we go. If you get hit with a hammer or something, it sends a message in and it goes all the way up into the brain, and it gives you this very accurate, precise perception of your pain. So you're like, it hurts exactly right here, and they tend to be more associated with sharp pains. But then there's these other ones. So there's this one where when you stimulate the nerve receptor or the nociceptor, it goes in and it travels up, and it goes up both sides, and it bombards all of these autonomic nerves: digestion, respiration, sexual functions, all of these things in your brainstem are being hyper excited by these older pain pathways. And then up here, if you look, you can see where the red is. These are going into more older pain pathways related to emotions and things like that. And then this one, it didn't play, but it's doing a similar type of thing, and it's a very, very old pain pathway. Oh, here it goes. So it's just a different one. So what happens is, as the doctor, what we work on here is we understand each of these, and we understand that they're presenting differently, and we're working to try to figure it out. Now, we also do a lot of what's called visceral manipulation. So people with acid reflux or constipation or diarrhea or different problems with their organs, we evaluate the function of those organs, we listen to the people, and then we work to help them with it. And there's a special class of pain receptors in your organs. So like this is really important for you because you do work with environmental toxicities. So what happens is the environmental toxins go into your body and they change these silent nociceptors. Silent nociceptors are real hard to activate. They're all through your organs. But once you activate them, they stay a little overly active and they become very easy to activate to the point where you eat and your stomach hurts or something. And these, when you look at them, they're coming from your organs and they're traveling in and they're going up all these older pathways. And then when you look here at this green area, which is your cingulate gyrus, this is suffering. This is where suffering is experienced and housed in many, many ways. So the information from your organs goes into these older parts of your brain that are associated with pretty profound emotional experiences and suffering. So we have these different pathways, and if you can understand them all, it makes it easier for you to help people. As someone suffering with these, it's really confusing, particularly because one day it could react differently than another day. So now we're just going to look at just the general type of how can you block pain. So what this shows is that the hammer is going to hit the hand and the messages are going to go into the spinal cord, which is over here, and go to the brain. But then if you rub there, you block it. So you can see here you're blocking the pain. So we could watch it one more time. So let's see. There we go. So as these messages travel in, they're sending these pain messages to the brain, but then you rub it and you see it blocks it. And this would be at the spinal cord. It's just the picture doesn't show it. And now the pain messages don't go to the brain, but movement messages do. So movement blocks pain. If you're healthy, unfortunately, if you become unhealthy, then you get sensitized, and then the movement causes the pain. But ideally, this system's working. Now, at a higher level, you also have up here some areas in your brain that send chemicals back down to your spinal cord and actually up to block the pain. So as it comes in, you have another system that's related to blocking the pain where it activates it and it sends the message down and it blocks it at the spinal cord. So you have more than one way to do it. So this one, I just put the one picture in. This is a serotonin pathway, and they're here in your brainstem. And what they do is they send messages back down to block pain, and they send messages up. So now you have your receptor, information goes into the spinal cord, it goes up and it activates. These are all different parts of your brainstem for organ function, breathing, all these things. It goes into your emotional brain and your higher brain. But as these get activated, these things, these all have names, so like periaqueductal gray and different parts of your brain send messages back down to block the inflammation at the cord and up to block it at the brain. So you have these protective mechanisms. Unfortunately, if you have ongoing pain, what happens is your brain actually rewires itself and you lose the perceptions of where your arm really is, or where your head really is, or where your leg really is. So what happens is these are maps here in the brain that we've been able to look at. We electrocute it and the person can feel it. And they're really well known and understood that we have these maps. So this part of your brain does your hand and this part does your face. Here's your feet and genitals are right next to each other. So, but when you have pain for a long period of time, it spreads. Some of them are more natural to spread. So when we look here, this is a picture of your neck, and these X's are what we call trigger points. And this neck muscle's here. It helps you to turn your head and move and stabilize your head and hold things in place. So this is called your sternocleidomastoid. Well, where these X's are, they commonly will send pain into these blue areas. So into your ear, into your forehead, into the side of your head. So what we do is whenever people have these chronic head pains, we look at it. Do you want me to move anywhere or anything?
It's just a struggle at this point.
I can slide over.
That'd be great.
Yeah. I just don't want to
Yeah, I
tear
don't know if that's
anything.
gonna work with the cables.
Yeah. Well, it might, right? How far do you need me to go?
That's better.
I'm going to think positive and not experience pain because of that. Okay. How's that?
Great.
Is it really?
It's better.
Okay. So the more over here I go, the better it is? Okay.
Until, well, you're good there because otherwise you'll block the screen.
Okay. So this is the best?
Yes.
All right, great. Well, let's do the best. So, so these are called trigger points. And again, I'm a neuromuscular therapist. So this is the thing. A lot of times medical doctors will inject these with like lidocaine and different salts and things, or people will do needles, but we can go in with our hands and we can work on these, and they're pain generators. And this is just a few of them. So this is the SCM. And then I put one over here on the far one where you see the trapezius muscle, and you just pinch in here and it'll cause pain. And a lot of times people will say, oh, you have these, but you should be able to pinch it and it should refer the pain. And then if you treat it and it goes away, what happens if you're a migrainer, and we know that migraines are actually really central pain syndromes, they're not really related to your shoulders and things like that, or this, but it's still part of it, because if you're getting this nociceptive barrage from here, then it's changing the activity of your brain and it's making the probability of you having a migraine higher. So what we do is we treat these to lower the probability of having the migraine. And a little later I'll show you that it's not a definitively known thing, but we do it here because we personally find it to work. So when we do it, we get good results with it. This picture is showing where different joints send pain. So, so like up here, this comes from this joint, and here is more this joint, and the ones down here come from the lower ones in your neck. So we know that different joints have probabilities of sending pain to different places. And again, we have very gentle ways that we can improve the health of that. And we also have some other ones, where you just move it really quickly. and line it up. And so we look at those. Then you have organ referral pains. So for instance, if somebody has a gallbladder problem, they tend to get pain in their right shoulder. And even on this picture, you can see over the heart where the red is, and it goes down the arm. There's gender differences. So males have higher probabilities of doing the arm thing. Women have a tendency, it goes up into their jaw or even goes to the other side. So we know that these maps have like secondary maps, and there's organ maps, muscle maps, joint maps, and there's all these different maps that can cause pain. And what we like to do is we like to understand all of them, and then we like to look at all of them, and then we like to try to solve all of them for the person. Instead of being a specialist in only one, we really try to understand each one. And then there's these peripheral nerves. So this is another different picture of where nerves from your head can come up into here. Unfortunately, I don't usually see it be the greatest therapy in the world, but one of the things that happens is this. So when you look at the back of the head, and we're looking at this picture over here, the nerves come out, and the white stuff is the fascia. And the nerves go through the fascia, and then they go up the back of your head, and they can cause pain up onto your head. And you see on the far picture over there, they're showing you, oh, look, these things can cause pain. So what they do is they'll cut the fascia to try to make a bigger hole for the nerve. But what we like to do is we like to try to work on it and get a better fluid dynamic and get it to slide so that it doesn't compress it. Or they'll do some things called radio frequency ablations, where they fire radio waves at the nerves and they just kill them. And they go, well, if we kill the nerve, then it can't send pain messages. But unfortunately, if the nerve's not really sending pain messages, it's sending nociception. And nociception might be associated with pain, but it also might be very healthy for you. You have a lot of nociceptors. So when you kill them, you have a probability of developing a central pain syndrome, because your brain needs the stimulus from your world. And if you cut the nerve, you can get a central pain syndrome, like in a phantom limb. So we like to approach it a different way if possible, which usually we can. So these are the different pains. So neurogenic, like these nerves going up your head. Myotogenous, like trigger points in different areas. I didn't go through all of them. There's a bunch of others that we like to look at. Sclerotogenous, which are from your joints. Visceral, which can be coming from your organs. And then when we look at this, we have central. And so as we move into the understanding of migraines, you're really looking at these central pain generators. So now we'll kind of move from what is pain, how does it work, what do we try to do with it here, and we'll move a little bit more toward a central pain syndrome. And so, and the one that we're talking about is migraines. So let's see if I can just kind of come out of here, and then we'll go to this maybe. Okay, so this is the Mayo Clinic website, which is, you can't see yet, but I'll get it for you. No, I don't know. I mean, I'm clicking a button. I'm clicking all of them. Click every button there is. Okay. So this is the Mayo Clinic, and so let's look at what the Mayo Clinic says, because they're for sure one of the great leaders in the world in medicine. So
Hi.
Can you hear me?
A neurologist at Mayo Clinic, and I'm here to answer some of the important questions that you might have about migraine.
Let's move this. Or
Migraine is a
that's
disease
good.
of abnormal
Or-
function within the setting of
know.
normal brain structure.
It's okay.
An MRI of the brain solely tells you
It's all right.
about the
We'll just
structure
deal
of
with
the
it.
brain.
Here,
It
can
tells
you
very
want to hit the
little about
pause?
the
Watch out,
function of the
don't
brain.
trip over things.
And that is why migraine
Huh? Oh, are you? No, don't hit it yet. You want to stand over there? Yeah, just, there we go.
brain doesn't show up on an MRI because it's abnormal
hit replay.
function
Hop in there.
in the setting of normal structure.
Yeah.
Hi, I'm Dr. Amal Starling, a neurologist
I have
at
no
Mayo
idea.
Clinic, and I'm here to answer some of the important questions that you might have about migraine.
He's okay.
Migraine is a disease of abnormal function within the setting of normal brain structure. An MRI of the brain solely tells you about the structure of the brain, but tells you very little about the function of the brain. And that is why migraine doesn't show up on an MRI, because it's abnormal function in the setting of normal structure. Migraine is highly disabling for some individuals. In fact, it is the second leading cause of disability worldwide. Disabling symptoms are not just the pain, but also the sensitivity to light and sound, as well as the nausea and vomiting. There is a wide range of disease severity in migraine. There are some people who only need a rescue or an acute treatment for migraine because they have infrequent migraine attacks. But there are other people who are having frequent migraine attacks, maybe 2 or 3 times a week. If they used rescue treatments for every attack, it could potentially lead to other complications. Those individuals need a preventive treatment regimen to reduce the frequency and severity of attacks. Those preventive treatments might be daily medications, they might be once-a-month injections, or other injectable medications delivered once every 3 months.
You can hit pause there. Okay, so, thanks, man. So a couple things there that I think are just very interesting is that for sure, migraines aren't about the structure, they're about the function. And the nice thing is here, we're chiropractic neurologists, or sometimes it's called functional neurology. We had the really good advantage of working very closely with Professor Carrick, who's considered the father of functional neurology by many people. And I was fortunate enough to be his first assist. So we've spent a lot of time working in this arena, working to help people with functional neurological problems. Migraines are functional neurological problems, according to Mayo Clinic. So when you run an MRI and you look at it, you don't particularly see anything because its function, our technology, is just not quite good enough to be able to see these things. And then when we look at some of the treatments that are commonly used, they're pain relieving medications and preventative medications. So if you look at some of the medications, okay, you have aspirin and ibuprofen, but the problem with these is that and I'm just reading from the website, so I'll try to keep the cursor here, but I don't know if you can see it at home. But the problem with these medications is they cause headaches. So the medication can cause a headache. So it can cause overuse headaches, ulcers, bleeding, and gastrointestinal tract disorders. So the thing is that, man, I have a lot of patients who wish they only had migraines 3 times a week, right, Dr. Bouth? I mean, 3 times a week's a dream for some people. So they would be taking these things all day, every day, and they get ulcers and they get intestinal damage, which can be a real challenge. There's other meds called triptans that block pain, and you can do these nasal sprays with them. But don't take them if you're at risk for a stroke or a heart attack. So I think that, that is a large percentage of people. And so this one has worsening of migraine and worsening of vomiting and worsening of nausea. So as you go through the list of medications, the challenge that we face in medicine is when you try to make a medication that helps one thing, it's very, very difficult to keep everything else in balance. So I think with an apple, I think there's over 10,000 nutrients. I don't even think we know what they all do. So, but with a medication, you can have an isolated chemical, and it doesn't have the synergy that we see in nature. And that synergy that we see in the world that was created for us helps to keep things more well in balance. We have a hard time to balance that when we try to create a medication. You can also use blood pressure lowering medications. You can use antidepressants. So unfortunately, the people have migraines and they go, well, are you depressed? Do you have anxiety? And it's like, yeah, if you thought your head was exploding right in the middle of dinner and a light was piercing through your eye, you would probably have some anxiety as well. They give you anti-seizure medications because the idea is that they're depressing the activity of your brain. And so they lower the activity of the brain. You don't want to take those when you're pregnant, and they can cause dizziness and weight changes and things. Botox injections, I tend to see those have a hard time for people, but the idea with the Botox, I think, is to relax the muscles, which we more try to do with our hands. And so those are the things for the medications. Now, interestingly enough, they have some other things. So they say, well, try relaxation techniques. And so what they find is that if you can do these relaxation techniques, you can reset your nervous system to a certain level, and it has some benefit for the person. I'm going to show you neurophysiologically how that might work. Sleep better and eat better. So sleep has regenerative properties for you, and it shifts your brain activity, and eating changes inflammation, like the silent nociceptors in your intestines and things, and it gives you better food. Drink water. Your brain has a very large percentage of water, and water is important. People will keep headache diaries. I think it just helps them to do it. And then exercise regularly. The only problem is for some people the exercise is a trigger for them. But those are the recommendations in medicine today. So that's what it is. That's fair, and that's how it works. But some of the challenges that we have with that are, again, we really kind of discussed it, but taking the painkillers can trigger overuse. And unfortunately, we've ran into this problem recently with opioids. And opioids were being overprescribed, and they are very addictive. There's some really good documentaries out there now on it. So approximately 4.5 million people are addicted to prescription opioids. So I think it's fair to say that it's okay to try conservative therapies before you progress into opioids. 80% of the consumption of opioids in the world is in America, so we're probably overprescribing them. It's $56 billion a year. 25% of all workman's comp cases are related to opioids. It's a big problem. It's very difficult, and they're prescribed for people with migraines. So this next slide's a little bit lengthy, and I'll try to explain it for you. I wanted to try to thin it down a little bit, but I really wasn't able to. But the point of this is to say, neurophysiologically, how does relaxation and cognitive therapies help you with pain or stress or your sympathetics? How does it improve it? And so this is a diagram that I made on how you can rewire your own thinking, okay? So what ends up happening is you have a negative thought, okay? So I don't know if you can see that there, but we're going to call that a negative thought or a negative experience. And that negative experience triggers a feeling. So all of a sudden you have this emotional brain. You have a feeling like pain. Remember, pain is a feeling. It's not just this mechanical thing. It's an experience. Well, that experience triggers a thought. So now you might have a fear or a stress. It's said that pain is like learned. So now you have this negative experience, you have a feeling, you have a negative thought. And what it does is it begins to what we call plasticize. It begins to grow, particularly if you keep having the experiences. And the negative thought, or the lie, frequently, we can call it a lie sometimes, reactivates a negative experience and a negative feeling, and then that can lead to a disease problem. So these negative experiences can cause inflammatory changes in a person's body. They can cause incorrect tensions. They can cause alterations of behavior in wanting to eat more or not wanting to eat, and they can lead to diseases. This used to be soft science, but it's not anymore. Now it's very well understood. I took a class years and years ago on this, and now it's actually very well understood. How much? To the point that it's on Mayo's recommendation list. Then the disease state goes and it reactivates this negative experience, and then you begin to plasticize this environment, and it just loops. Now you're stuck in that loop, and you're in that loop in your life, and you somehow have to work your way out of it. If we can get you out of pain or get you healthier, we can help you to get out, but we also have ways of helping people reframe their perceptions of their life, or there's good books on it, and you try to shift it. Well, let's say you do that, and you activate this whole pathway, but then you activate your executive brain. So your executive brain is this like higher frontal lobe, and you say, hey, wait a minute, I don't accept this fear thought, or I don't accept this stress thought. I'm not going to view it that way anymore. I'm going to change the way I view it, and I'm going to tell myself something more true. I'm going to tell myself this. Even if you don't believe it yet, you start to rewire. It's really hard the first time you do it, you know? And you try to rewire this thought, and then you get a positive feeling. And then when you have that positive feeling, you start to create this loop where your executive brain takes this negative thought, this negative experience, gives you a true one, and generates a positive feeling. Well, the more you do it, what ends up happening is you get faster at it, and you get better at it, and you can generate those positive feelings quicker. And then you learn before even the thought happens. You learn when that feeling occurs. Boom, your executive brain jumps in. It says, that feeling's not even true. This is the reality, and you start to create positive feelings and better hormones and better blood flow and better activity, and you change your brain's integration, and you literally start to rewire your brain. Well, once you do that, what ends up happening is eventually it will start to reabsorb these things down here. They actually, it's called negative plasticity. You actually reabsorb these different areas, and they start to go away, and the positive feeling can come down, and it can begin to impact your disease state, and your disease state can heal. you're capable of healing. So when you look at psychoneuroimmunology, they look at the power of the mind in healing, and it's being shown that you can shift your focus and your thought, and you can actually heal. And then as you start to get this positive healing mechanism, you activate your executive brain. So these go up here, and you begin to plasticize this more truth. So even though you might have these life experiences that were horrible and that were negative and that were painful and that led you to believe lies earlier in your life, you can rewire those experiences, and you can begin to, with your higher brain, turn them off. Let's see how these go. So then you actually block it. So then you block that thought, and it actually stops occurring. So even though these loops are happening from your life, what was meant for bad gets used for good. And you begin to plasticize more positive feelings about truth, positive feelings about healing, positive feelings about health. So you take this aberrant experience over here that perpetuates negativity, illness, and bad things, and you rewire it so that you have health and good things. And that would be considered a real phenomenon that is mechanical, that we can do. And even in Mayo, they say, hey, that's a thing. You can work on that. Now, will that get rid of your migraine? I don't know about that. I think you need other things involved. But this is just educational to say, hey, neurophysiologically, how does that go? So I love this picture. Love, love, love this picture. So there's this young girl here, and she's in Iceland, and she's just rewiring her whole life and just embracing a new future. And her mother wrote this, I think actually they posted it on Facebook, but this was a patient of ours. And it says, to many, this picture captures our planet's natural beauty. I agree. But to me, this picture brings to mind joy, hope, and happiness. 2 years after my daughter played what would be her last soccer game, we brought her to Georgia Chiropractic Neurology Center out of desperation. I think they were from a different state. So we had gone to many specialists, and no treatment was making a dent in the pain my daughter felt every day after sustaining her second concussion. Her smile, the light in her eyes, and her adventurous soul was slipping away. The last days at GCNC weren't, or the days at GCNC weren't easy. They weren't easy. But the doctors there and the staff developed a customized treatment plan that gently pushed her brain to begin to heal. And that gently part's so important, because one of the fundamental things that we do here is that we look at how much you can handle, and we set your care at that level instead of sometimes pushing people too hard and they can't handle it, so it doesn't have the right effect. So we try to set it at the correct level for the person. So we have gentle techniques and moderate techniques, and then really more aggressive ones of push-ups or running or whatever that person might need. So she's still healing, but as you can see, living her life to the fullest. So this picture of her in Iceland backpacking through Europe represents much more to me than the combined beauty of the rainbow and the waterfall. The fact that my brave daughter is standing there in a far-off land, soaking it all in, to me, the most breathtaking, beautiful thing of all. So, it was just incredible. This kid couldn't really leave her house. And then there she is in Iceland. It was just the coolest. I really, really, really love it. So I gotta go out of here again. Now we're gonna switch more toward the book, like we had talked about. So let me see if I can get out of here again. Technology, pros and cons. Yep, gonna have to get this. Sorry. This is the pushing buttons rapidly thing. There we go. Okay, so this is a documentary on migraines and its streams, but this is just like the introduction, and I just thought that I would play it for you.
Well, I have it right now.
Migraine is so much more than just a terribly disabling headache.
I couldn't feel my hand.
I lose language.
I don't see anything except for shapes all day long.
My daughter, Emma, came to me one day and told me she couldn't see. That's it. She just couldn't see. The next time it happened, it came with vomiting and a headache. She was desperate, and I was uninformed. So we took the first recommendation we got.
I had a pretty bad experience. He said, I can give you a drug that will make you fat and bald, or I can give you a drug that will make you thin and stupid. And I said, thin and stupid, please.
We do not have good medical treatment for people who have chronic forms of the disorder.
If I can cure your migraine, I'm going to get the Nobel Prize. That's how big that is.
By setting out to help my daughter, it seemed I'd stumbled into an entire world of hidden suffering.
Freud had it. Thomas Jefferson, with 6 solid weeks of headaches before the 6 solid weeks where he wrote the Declaration of Independence.
Wayne Wade out with a migraine.
It's a big struggle. My vision goes. Of course, you get the pounding headaches, the vomiting.
The common refrain for people who have migraine is no, no, no.
It's not just a headache. Well, I think we need to take that actually a step further and say it actually is not headache at all.
And I don't see the F anymore.
So now we move into our section of the talk of getting a little bit into what are migraineurs really experiencing, and there's so much here, and it's so important because the reality is migraines are not, maybe not just headaches. They're far more than that. And a lot of people are experiencing these things, but they don't understand what they are. So for us, we have this really good advantage because we'll have patients come in and they'll go, it's the strangest thing, like my arm, this arm feels bigger than this arm and it hurts or something. And the people think I'm crazy. They're giving me antidepressants. Well, the reality is, if you just look at the experience of a migraineur, you know that this happens and it has names and it's understood. Or there's bugs crawling on me, or I feel movement. So what we'll do is we'll go through this book and we'll take a look at some of these things. So the onset of migraines can occur during infancy. Just imagine that, during infancy. The earliest recorded case of a 1-year-old boy, but in the majority of patients, symptoms start between age 6 and 10. A family history of migraines is common in these people, reflecting the inherited nature of migraines. So in this picture, you have the parent passing this experience of migraine to their children. It's questionable whether a person can have migraines without the proper inheritance. In those cases in which one cannot learn of typical migraines in the family history, one can sometimes get a story of a relative with a typical temperament or one who had an occasional scotoma, which is these little spots in your visual field. Thousands of persons have migraines so mild and atypical that they never know what it is. So this is the thing, is that when you think, oh, the migraine's a headache, it's not necessarily, and a lot of people are having migraines like a visual problem or a strange sensation in their body, and they never know what it is, and there's no help for them. They just go about their life with this experience, not knowing what's going on. In preschool children, maybe they have vomiting or abdominal complaints. So people with this chronic abdominal nauseas and things can be forms of migraines. But they don't usually have headaches. And if they do, it can only be inferred from behavioral changes such as head banging or holding their head. A typical migraine episode in infancy would be crying, irritability, photophobia, or sensitivity to light. You get pale, maybe you vomit. But studies suggest that migraines will strike 5% of school-age children, and it doesn't get diagnosed. So that's what's happening for them. You have these acute migraines. So there's different types. So you have an acute migraine, and the main part of an acute migraine is the headache. So that person goes, oh, I have a headache. But there's different features of these headaches, and we'll look at it. The word migraine came from half-headed. So there's this idea of like, well, migraines are only one-sided. But we'll look at some pictures in a little bit where they're on both sides. Typical characteristics of migraine headaches will be in these pictures, including headache on one side, pulsations, maybe moderate intensity, maybe severe, affecting your daily activity, nausea, hypersensitivity to light and sound. And so, but the thing about this art is they went through and they looked at these people's art, and they looked at what percentage of the people drew pictures that were only pain on one side, or what percentage drew pictures that were only pain on the other, or what percentage had halos. And so they went through and looked at it, and what we see is that it's just not classic for what a textbook would say. So you have 173 pictures, the pain shown in different ways to be on one or both sides of the head. And so 85 migraine art pictures, well, 88 of the pictures, the person had them on both sides. So these are their pictures, and the person is just grabbing and they're feeling this. On the picture over there, what the person did was they drew this red, but they drew their head exploding. So the person had a sensation of their head actually exploding and the red contour moving across into the other side of their head and shooting down their shoulder. So they're drawing this picture of this red mass cutting through their head down their shoulder and causing their head to explode. And so they're looking at these pictures in different ways. Sometimes there's a pulsatile quality. So the picture shows a person with this mallet being held by their own heart, and their heart is smashing them in the head because every heartbeat is causing this pulsatile pain syndrome that is debilitating for the person. And so there's these pulsatile pains. Sometimes what they'll do is they'll try to cut the artery off of a nerve or give you a blood pressure med or something like that. A lot of times what we try to do is we try to locate maybe how to calm your sympathetic nervous system down. So your brain, your sympathetics fire high in childhood. So a child has a higher heart rate and their digestion's slower. And then as your brain develops, you inhibit your sympathetics. It calms it down. Well, some people that doesn't happen for them. So we look at these higher brain areas and we look to see how are they working. And we can monitor that by looking at eye tracking techniques or the speed of different movements or cognitive integrations. And we look at that and we say, well, we think that if we activate your higher brain center, we could calm down your sympathetics. And if we do that, then we get a chance to remove this pounding experience that you're having. And then I always like to do some fascial work to work to calm that down as well and try to remove this thing where you feel like your own body is attacking you. Some people have headaches at night. So this person was drawing that here there's this clock, and at 3 o'clock in the morning, they get these stabbing pains in their head for 4 nights in a row. So for some people, they get nighttime attacks, and you might have to look at, well, what would happen with that? What are the person's circadian rhythms? What are their light responses? How is their sleep? What are they thinking before they go to sleep? Can we try to stabilize these kinds of things? So you can have these nighttime attacks, and then people will get nausea and vomiting. So a lot of times they'll get nausea and vomiting, and it was in 40 of the pictures, but I didn't put any of the pictures of the nausea and vomiting on there, but they'll change their own complexions, and then they would just draw, like the one person drew themselves vomiting in a toilet. So they have this pressure in their head, but after they vomit, frequently they'll feel better. People get extremely light sensitive, and a lot of times people just don't understand that just driving down the road and the light flickering through the trees can give a person a migraine. And so here the artist drew this person stabbing their eyes with light and shining light on them and attacking them, and they're here in the bed with all their medications around them, and they'll just wear glasses, and they'll stay in there. So you have this photophobia or hypersensitivity to light with the migraine. And a lot of people are hypersensitive to light, particularly after concussions, or people after post-COVID attacks now are getting these dysautonomias, and they're very sensitive to light. So they'll try to block it. 6 pictures of photophobia with intense symbols indicating that it should be blocked. And so basically people get very light sensitive, and they get sensitive to motion. So this is a thing over here. They say the forms of photophobia may be motivation for people to avoid light, but it's also movement. So they can't handle people moving around them. Or even when I move here, I get different light aspects. So they become very sensitive to movement, and it feels terrible because you go, well, you don't want to tell the people around you to quit moving. Like, you don't want to say that to them, but their movement is injurious to you, and it's very, very difficult. So photophobia can persist during headache-free times, suggesting subclinical migraine or predisposition to migraines. So people might not realize it, but they just don't like light. They don't even have headaches. And they really have this like pseudo migraine thing. So they just don't enjoy it. They're always, hey, could you dim the lights? Or they're trying to go to school as a child, and they just don't understand why it's hard for them, because they have this subclinical migraine, or they maybe have a predisposition to migraines. Like maybe they're okay now, but if they get a head injury, then they turn into a migrainer. It's better to fix the person before they do it. So the mechanism that causes hypersensitivity to light during a migraine has been theorized as a loss of inhibitory processes in the subcortical part of the brain, which may normally suppress sensations of glare and light induced by pain. This idea is consistent with medical findings in patients with brain lesions that suggest losing inhibitory processes in the brain and the thalamus cause exaggerated senses of glare. So what they said there was that you're always blocking activity. So you don't realize it, but you're always blocking activity. So there's a whole millions of nerves that are inhibiting other nerves. So there's nerves that inhibit nerves for light. So like right now I have a light source over here, or here I'm looking at Michele. And so I look at him, but when I turn and look over here, I don't still see him. So I see him, light is reflecting off of him and hitting my eyes. When I go over here, I don't see him anymore because my nerves that inhibit that are turning it off. Well, people with migraines, those nerves aren't active enough. So it seems a little odd because you're trying to calm everything down and turn everything down. But really what you have to do is you have to activate the system at a healthy level so that the inner neurons that block light work better. And then your brain lowers its experience of the light and you can tolerate it more and you can enjoy it and you can enjoy your life. And so for us as functional neurology practitioners, which these are problems of functional neurology, we understand how to go in there, evaluate the person, do therapies that might not be, flashing a light at them, but might be something else, a different movement therapy or something, to activate the regions to help them inhibit the experience of light. And so that's what we do. And so then you could take this person who's got these little matchstick fire people that are shooting lights at them and drilling holes in their head and torturing them, and you can make them go away. This is very emotional. This is very different, again, than, say, shin splints. People don't tend to perceive creatures kicking them in the shins. Migraines are very, very different. They're literally experiencing like Woody Woodpecker smashing through their head. And because they're affecting parts of the brain that are connected to emotionality and parts of the brain that are related to vision. And when you affect a part of your brain that's related to vision, you actually might see something that's not there, or you might feel something that's not there. So they're seeing and feeling things like creatures literally smashing them in the heads. But they can't go tell people that. They're afraid they're going to be ostracized. And of course they would. But they draw it in their art. So this person has phonophobia or other hypersensitivities. So what happens then is people get sound sensitive. So they are drawing this like rumble, rumble, rumble. It's just a car driving by, but the car driving by, they can't inhibit the sound. They're tortured. Or they're at dinner, and for me to be at dinner and for me to listen to you while he's talking, I have to focus my brain to you, but inhibit you a little bit. And if I can't do it, then it's torture. So it's like around the food, you're being tortured, or a motorcycle, or a clock ticking. You know, back in the day when clocks had hands, you know, it was like chick, 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 drives people a little nuts. But for some people, it tortures them because they are a migrainer and they just can't turn it off. There's a thing called misophonia. Misophonia is really, really odd because not all sounds bother them. It could just only be certain sounds. Like it could only be the sound of one person chewing or the sound of one person walking. Like people walking don't bother me, but you walking drives me insane. And they get these misophonias. They're pretty hard to help. We've done really well with a lot of them, but not all, you know, and there's whole misophonia groups out there, and they're difficult. But here, the drums of maybe their child or somebody that they love are hammers smashing them in the head, or the horn of a car, or people get these teeth pain. You know, it's really interesting, but people don't realize it, but sometimes they have pain in their teeth, and they go, well, maybe you have a cavity, maybe you don't. We can't really see it. So we're just going to drill it out. But actually what they have is they have brain-based pain. There are phantom tooth pains. So sometimes people have phantom tooth pain and nobody can figure out what's wrong with their teeth. It's a brain-based pain. And we've gone in there before and located the cause of that, treated it, their phantom pain goes away. That tooth pain goes away. I got to tell you, they are really, really, really happy about that. So people just have intolerances to noise and sounds. Let's see, Kaya and Hood, in 5 cases from a group of 200 migraine sufferers, people had hypersensitivity to sound, at the same time having a hearing loss during the migraine. So this is sort of an odd thing where a person has a hypersensitivity to a sound, but they have a hearing loss. So like they may lose their ability to hear speech or something, but this other one thing goes really, really high. So what's happening there? Well, what's happening is that if you hear a tone, like an A, so you hear this A, well, the tone next to it gets dampened, so it goes down. So that way you could hear this one better. So what can happen is, earlier we said that the inhibitory neurons fire lower, or one part of your brain fires lower, and it's not controlling the other. So stuff comes through really, 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 really loud. Well, what can happen is you can lose your ability to hear one thing and lose your ability to stop hearing something else. So that happens, and they've seen it in multiple people. So this seemingly paradoxical observation could be explained by a transient disturbance in the receptors of the inner ear. So this is another thing. Your inner ear has these hair cells. They're really sensitive to antibiotics. Antibiotics damage them. Aspirin damages the hair cells in your inner ear. But they can have alterations in their mechanics too that change and upregulate and downregulate the activity. This phenomenon is recognized in one of Alice in Wonderland through Lewis's Carroll's Looking Glass, where the noise from a multitude of drums rang through her head till she felt quite deafened. So it's like she heard it, heard it, heard it, heard it. It stimulates it too much. Remember, we said that when you're trying to treat a person, you have to treat them at the correct level. So if you stimulate it, stimulate it, stimulate it, stimulate it, then all of a sudden it just can't keep going and it goes flat. And so again, this is one of the key things that Professor Carrick really, I think, pioneered, which was to find the correct frequency of activation and not overstimulate it, because if you overstimulate it, they metabolically can't endure, they can't keep up. So what we do is we're always watching heart rate, blood pressure, pupillary size, skin color, skin temperature, and we're picking a gentle therapy. So like the girl in Iceland, her mother said, the days were hard where they were picking the gentle therapy, and you're just sitting there and you're meticulously rebuilding this person's nervous system, and you're meticulously recalibrating their nervous system, and we're constantly monitoring it. So one of the great things about, I think, our advantage is that as chiropractors, we're physicians. We're trained in blood chemistry analysis, visceral diagnosis, cardiac diagnosis, cranial nerve diagnosis. And because we're physicians, we had a really good ability to do an exam. Then we did a specialty where we trained in chiropractic neurology from the Carrick Institute, and we learned how to take that information and apply it to neurology and monitor these physiological responses. So remember, the doctor from Mayo said it's functional. You can't see it on an MRI, but guess what? You can see it in other things. So I'll show you some, like your pupil size. In a little bit, I have a slide with this pupil size. Well, you can watch pupil sizes change. You can watch heart rates change. And so that's what we do here. I've been really fortunate to be a professor with the Carrick Institute. And so I teach people how to do the brain rehab, and then all my staff, we are constantly teaching and learning how to get better at monitoring these subtle signs and subtle indicators to be able to watch the physiology of what happens for the person and to try to recalibrate, the greatest mystery on the planet, which is the human brain, or even more challenging, the human mind, and to try to reset these things so that you get the proper brain excitation and inhibition to inhibit all these sensory stimuli, whether they're visual or sound. The visual system has a tendency to go to one part of your brain. The auditory system has a tendency to go to another. Different colors mean different things, and we'll look at some more of these. So some of the other symptoms that happen for people is that, here you go, facial pallor. So here it says facial pallor or paleness can be predominant during a migraine, and it's described as a white migraine or an angiospastic migraine. And this person up here drew themselves imprisoned but pale. Well, why? Because your sympathetic nervous system shifts your blood around. Sympathetic, parasympathetic. A lot of people really enjoy the polyvagal theory, and they look at the vagus nerve, and if it's too sympathetic dominant or too parasympathetic dominant. But look, that's only one nerve. The guy wrote a whole book on one nerve. It's a great book. It's really brilliant. It was just one nerve. There's a whole bunch of other ones that are doing it too. So it's not just, only look at this vagus nerve. There's way more to it. And when these happen, you can get pale. And guess what? When that happens, you're not getting as good a blood flow to your organs. And when you don't get good blood flow to your organs, you don't get good oxygen, and you don't get good nutrients. And when you're not getting good oxygen and nutrients, you inflame, right? You inflame, and then you start to damage your organs. Well, guess what? They're feeding back up into your brain and giving this nociceptive barrage into these old emotional systems, these old emotional suffering aspects of your brain, and potentially promulgating this experience of migraine. So we work to go in there and find that. Or you could have this facial flushing where you get red. So this picture down in the corner is the opposite. They don't go pale, they go red. So what's happening there? Well, that is a different mechanism. Now they're shunting blood up into their head, and they're pressing the blood up into their head. Higher probability of having pounding migraines with that type of a situation. So how do you treat a person with a migraine who has a facial flushing differently than somebody who has where their face goes red? They're different central mechanisms. You can't go, oh, you have a migraine, here's the treatment. They have to be individualized. I think it's better if you can do it. So we're looking at all these things and we're going, well, we can't really see your brain, but we know that one part of your brain moves blood to your periphery and one part moves it to your organs, right? And so we can watch that and we cross compare it with the other findings, and we try to solve these problems. That, remember, the one guy on the video said, if I could cure migraines, I get a Nobel Prize. So it's not that we cure them all, or it's not that we cure them all 100%, but this is the approach that we're using to figure it out, like for you, for that person, what's happening for you, and then how do we go in there and shift it and improve your life so that you can go out, so that you could go to Iceland. Even if it's a little hard for you, you go to Iceland, you take it in and you rewire your brain and you regain that strength, and then you can come back and we can keep things going until we see how it goes. So here there's this enlarged pupil on one side, and it's abnormal. So here, if you look at this person, this pupil's really big. Well, you have one nerve in your eye that dilates your pupil and another nerve that constricts it. The nerve that dilates your pupil is more sympathetic. So that's a fight or flight nerve. And you, boom, you dilate your pupil so that you can take in more light so that you're ready to react, so that you can see everything. Well, unfortunately, if you're light sensitive and your pupil dilates, then the light creates this piercing, torturous pain. So you see here, with her pupil dilating, she's hyperreactive to light. And it's difficult. Well, that lets us know that, you know, the sympathetic's firing high for that person. And how do we work on a parasympathetic activity for them? And there's certain nerves that are more parasympathetic and things that you might be able to do. What's her heart rate doing at that time? Is her face getting flushed? Or is it getting pale? What's the bowel sounds doing? And we're monitoring these physiological responses, and we're working to change this. So the dilated pupil is a rare feature in migraine attacks, and it's consistent with ophthalmoplegic migraines where the eye muscle is paralyzed. But I don't think that they're rare. The thing is in medicine, I think it has to be like maybe a 4 millimeter difference, 2 to 4. Okay, so they go, well, that doesn't happen that often. But what if it's not to that degree? So a lot of times people have one pupil bigger than the other, and they say, well, that's normal. That's just normal. Unfortunately, obesity is normal in Georgia. And so, but that's not healthy. So it might be normal to have one pupil bigger than the other, but it might not be healthy. It might not be healthy for you. So a lot of people have this. We see it constantly. But they go, well, it doesn't happen that often. Bloodshot eyes. So again, the bloodshot eyes, the blood is moving into that eye. 4 pictures represent migraine victims as bloodshot together with the skull in one hand and the word help written on the inside of the pupil. So this person here has bloodshot eyes. They're having tearing. They're trying to get help. Tears are shown in 36 Migraine Art pictures. For the head, the female migraines suffer with tears falling into a large pool. As a nasal sign, one migraine picture includes a verbal reference to sneezing. That's terrible. I had a kid post-concussion, and his head pain was 10 out of 10. He would sneeze about 60 times a minute. And he was just sneezing and sneezing and sneezing and sneezing. And we got him better. I'm still in touch with them. That was 8 or 9 years ago. He's doing really, really well. He's off at college. He stopped in before he went to college, and he just stopped in to say, hey, going to college, thanks. Feel a lot better now. So, but that's terrible when they're sneezing while they have head pain or their sinuses are running. And so these are all signs related to migraines that people just don't, I think, give due attention to. Premature graying of the hair. So in this picture, you see the lady's hair on the right side is gray and on the other is not. And then you can see the ocular migraine that she's experiencing. So the effects of migraines have on my life is shown by my hair parting when at the age of 35 my hair went white and contributed to an early aging look. You know, that's pretty intense. Some people, their hair falls out. Abdominal symptoms. So there's things called abdominal migraines. The migraines in your abdomen. Some people think that fibromyalgia is really a migraine. It's just this whole body migraine. Because when they look at the muscles, there's nothing wrong with them. So there's no inflammation there. There isn't a problem. They just think it's a migraine variant. But sometimes people are having abdominal pains and they're actually migraines. So abdominal discomfort plus diarrhea was in 9 images of people with migraine attacks. And so you wouldn't think of it that way, but it can happen. So one aspect of migraines is that it very rarely covered in one aspect of migraine experience that's very rarely covered in scientific literature is the effect that the headaches have on work, family, leisure, and activities. Wallace poignantly states, migraines are an unsocial malady because they debar people from going into life. So, you know, we don't look at it that much, but it changes how they go through life. Here, they're having alterations of their own body. So I like this picture here where the person has weight on their head, but the weight's severing their head apart from itself. Or the person feels like a puzzle that's falling apart. These aren't simply pictures, they're experiences. So these types of things where a person depersonalizes and they fall apart and their bodies begin to move in odd ways are actual real experiences. Your parietal lobe is related to spatial awareness. You have spatial awareness of you in space. Remember, we showed how pain changed your brain maps, and we have ways of actually measuring the accuracies of your brain maps to see if you don't have an accurate map of yourself, and then we recalibrate them so that your parietal lobe works better. And when your parietal lobe works better, you feel yourself correctly, and when you feel yourself correctly, then your probability of whatever malady you're suffering from gets better. So these are things that are really happening for people in their minds. Abnormal body sensations, and there's a variety of different abnormal body sensations. So let's see. Sorry, just trying to monitor a few things here. So there's a variety of different abnormal body sensations. So there's a tri-dimensional concept of the body as a physical object, processing a certain shape, size, and mass, and occupying certain space and position in the external world. That's what we were just saying. Changes in the body image are classified by shape, size, mass, position. You know, this is one of the things, like for people with anorexia, they feel that they're fat, but they're not. They're thin because their body image is not accurate to what the rest of the world, to what we see. So the body images will literally change and fragment and shift like this. And people don't like to talk about it because what happens is, like, they might feel out of their body. So they can have this whole experience that they're out of their body or they're shifted. This is a real problem where people don't even notice it in a simple thing, just like knee pain, where they don't realize it, but, and this is real hard to explain, because if you think your body's further to the right than it is. So you think your body's over here when it's really over here. So what you do is you shift your weight over, and now your weight shifted onto your left leg, and you start to get these orthopedic problems on your left leg. And you go, well, yeah, I have all these knee problems and ankle problems and all this. But the reality is you don't realize that your foot pain or your knee pain or your hip pain or your back pain is because you had a distortion of your body image and you thought you were to the right, but you don't have a reference to see that about yourself. You can't see that you think you're to the right. We have ways to try to work that out for a person, and we have virtual reality machines and force plates, and we do a whole bunch of things to try to see, does the person really know where their body is? So you can have body images where the shapes is done. So this one guy had a delusion of a replication of a body part. He had a superimposed phantom limb where he had a third limb. I don't think I've ever treated a person who had a third limb. I've treated people who felt like their body was on the table and the ceiling at the same time. I've done several of those. Or they feel like their body's here and over there at the same time. Or people feel like their limb is bent So like they know, they're looking at it. They go, no, my hand's straight, but I feel it over here. They know they're feeling it over there. And then we recalibrate their central nervous system. They feel their hand where it is, you know? And so it's pretty wild. Well, migraineurs have this. It's known, unfortunately. People, remember earlier it said, oh, there's these subtleties of migraine where the person doesn't even know they're having a migraine. We read that earlier. And they're having maybe this light sensitivity or their body feels different. So they're having these migraine experiences, but people don't understand it. So they go in and they go, but I feel like my arm's floppy, you know, or tight. So they'll feel like their arm's tight or something. And it's not actually tight, but they're just having a disturbance of their body, and they go to doctors, and the doctors just tell them they're crazy, you know. So the person can have a phantom limb, and that was associated with the thing. And here it says the phantom limb would move in sync with the real arm, and the phenomenon would last hours and things. So this is what happens. Disturbance of body image affecting a position in space. So we talked about it. They'll feel like they're in different spaces, okay? So pain-related body awarenesses. Facing the many complaints of migraine, patients describing their pain experiences, Lebarek suggests that everyone suffers in their own way. Everyone suffers in their own way. It's such a hard thing because so many of us do that, and it's hard to go out and talk and feel like, that's why they like the groups, you know, what are those support groups, you know, where you can talk. But everyone's suffering in their own way. And it's true that migraine sufferers report a variety of pain sensations beyond the typical pattern of a migraine headache. Some have sharp, jabbing, ice pick pains, dull, pulsating. I'm going to go through a couple of them here. So this one is like sharp. So this one feels sharp. So they feel like nails going through their head, or ice picks, or lightning bolts, or things like that. This one, they have a hammer machine over here. And the hammer machine's just pounding away at their head, and they're locked in and kind of tortured. A barbed wired wreath pulled by the external torturer causes further pain, while another torturer bores down on the victim's skull. Sometimes they feel like a pressure, so this is like crushing pressure. Sometimes they feel this twisting pressure, but sometimes in this picture here, they're feeling a pulling, they're being yanked. Some people, they think they're so crazy, their hair hurts. So they're like, my hair hurts. You know, my hair hurts. I don't even like to tell people, but I have hair pain. You know, that shouldn't happen. People feel like their heads are being pulled and yanked. So you have compressions, you have pulling. These are the sensations of movement. So this one, it's like so much movement you can barely see it. But a large number of ants are crawling on this person's skin, pursued by an anteater. That's kind of wild. The sensation of insects on the skin called formication. It has a name. People feel insects crawling up their leg all the time. They don't think they're normal. It has a name, formication. It's suggested by 3 large ants carrying a leaf in the bottom right corner of the painting, and a mosquito moves along the eyelid, and a wasp-like insect hovers over the eyeball. That's a lot of different sensations for one eyeball. That's a lot going on in there. For those of you in the room, you know that cranial nerve 5 innervates that area, right? So you're going to want to look at how that goes in the different areas of it. A third type of pain for body awareness is constriction. So this person is feeling their head constricting in and crushing, but it's a body shape change. So some people will feel like their limbs are being crushed, and they'll have these different experiences. Dysmetropsia, okay, is visual hallucinations involving changes in size. And I'll just go through a little quicker for you, but here you're looking at this page, And what's happening is the Migraine Art is now wildly. So what you see is the S here is big and the N is big. But then other areas are gone. They have this scotoma, and then other areas are small. So this is all Alice in Wonderland. One pill makes you smaller, one pill makes you tall. So the people will see things further away or closer. When people see things closer, their head will do different reactions and they get neck pains. And so a lot of patients come in just for regular chiropractic care with neck pain, but they don't realize they're seeing their world too close. And they're going like that, you know? You can see some people who have similar things like that where they keep standing far away from you and then you step closer to them and then they step back, right? And then you step closer and they step back. Well, they might be perceiving you as really, really close. Or the ones who stand right in your face, you think, well, you're very up front, aren't you? But they might see you actually as further away. So it's pretty wild. This person saw themselves in a mirror as smaller. So it can be these very advanced hallucinations. You can get tilted vision. So tilted or inverted vision. People will literally, their world will be tilted. Now they might, so this is a thing, again, remember we were talking about you perceive yourself over here. So you lean over here and then you get these orthopedic problems. Well, what if you saw your world tilted? So what you would do is you would lean into it and then, or tilt your head into it. So you're tilting your head into this tilted world perception or tilting your body into this tilted world perception. Sometimes you see people walking around tilted. You're thinking it's orthopedic, but they might actually be seeing their world tilted. They'll lay down, everything's crooked, you know. All the stuff, and you ever go to someone's house and all the pictures are crooked? You're like, oh, wow. You know, do you have migraines? How'd you know? Well, all your pictures are tilted to the right. You know, you don't do that though. You just say, thanks for the tea and crumpets. So people will draw these tilts in their world. So this is, I think, one of the last ones here. When I was 3 or 4 years old, playing in the garden one day, a brilliant shimmering light suddenly appeared to my left, a dazzling light, almost as bright as the sun. It expanded, becoming an enormous shimmering semicircle, stretching from the ground to the sky with sharp zigzag borders in a brilliant blue and orange color. Then behind the brightness came a blindness, an expanding emptiness in the visual field. And so I could see almost nothing on my left side. If you can't see anything on your left, your whole left, your highest probability is it's your visual system on the right. So this is the thing. When you run the MRI and you go, I don't see anything wrong. How do we as functional neurology practitioners know that the problem's probably in the right? Well, you can't see on the left because we know the visual pathway. And the visual pathway is mostly going to go that way. If you can't see on the left, but you're also experiencing other emotional things that are associated with your right emotional brain, it starts to tell you, hey, one part of your brain's going low and another part of your brain's going high. Well, when you're treating a person and one area is low and one area is high, you have to be very cautious because while you're trying to bring one up, you might send the other too high, or while you're trying to bring one down, you might send the other one too low. So it requires this massively individualized approach to try to solve these challenges for people. So my sight returned to normal in a few minutes, but these were the longest minutes I had ever experienced. I told my mother what happened, and she explained to me what I had was a migraine. She was a doctor, and she too was a migrainer. It was a visual migraine, she said, or a migraine with aura. The zigzag shape, she would later tell me, resembled that of a medieval fort. And someone once called it a fortification pattern. Many people, she explained, would get a terrible headache after seeing such fortification, But if I were fortunate, I would be one of those who only got the aura without the headache. I was indeed lucky here, and lucky too to have a mother who could reassure me that everything would be back to normal in a few minutes, and with whom, as I got older, I could share my migraine experience. It was not always the giant zigzag. Sometimes the migraine I would see with my eyes fully closed, or my faintly and transparently kept my eyes open, tiny branching lines like twigs or geometrical shapes covered the entire visual field. Sometimes there were more elaborate patterns like Turkish carpets or complex mosaics. Sometimes three-dimensional shapes like tiny pine cones or sea urchins. So there's some theories that some of the early patterns in prehistoric cave art might have been migraines. They had these fortifications and zigzag lines and these sort of patterns that we just naturally see in life and in the world. And so this is the experience of these people, and it's real, you know, and it's very, very, very intense. I might just play one of these. Let me see if I can do it. This was such a great lady, and Heather, if any of you happen to know her.
As well as migraines, and went to a neurologist for a year and a half. Ran a bunch of tests, took medication. We actually found an herbal supplement that stopped the vertigo, but did not help with the migraines at all. And migraines were at the point where I was having 3 a week or so, and for about 5 years, and just miserable. And they just were getting worse. And somebody in Michigan, a friend of ours in Michigan, said that a relative of hers had come here and seen Dr. Ellis specifically for migraines, which we thought was crazy, and recommended him. So I made an appointment and came in, and he's gotten rid of 98% of my migraines. I'll have maybe one every 8 weeks. And when I have that one, I can take one medication and the migraine's gone within an hour. Where before, the migraine would last for days. I would take a pharmaceutical suitcase of drugs and finally get rid of the migraine after 24 or 48 hours.
So for Heather, you know, I think that's fair. That's a realistic thing of, you know, we got them from 3 times a week to, you know, once every 8 weeks or something like that. And it was more manageable. It actually turned out that we finished that off. We got her to where she maybe was having maybe a migraine or a bad headache just a couple times a year. And so she went a long time like that. Did really, really well. These are other people that we helped. And so it's just a different approach. And we're not saying that we're going to fix them all. That's just not how it works. But the approach that we look at is to look at that individual, understand the neurodynamics of all the systems, understand what pain is, understand the role of all the different environmental elements, and work to come up with something that can make a positive impact in that person's life, and just try to help them on this incredibly challenge. And if anyone sees this who doesn't have migraines, hopefully it helps you to understand how other migraine sufferers are experiencing their life, because it's hard to explain it to people who don't understand it. So I appreciate everyone's time. Were there any questions? So we're all set. Are there any questions? It's pretty good, right? That's a great book. I recommend getting it. It's pretty wild. And not just for migraines, but just to understand people. So thanks for your time. Do appreciate it. And next month, I think we're doing POTS. POTS. So next month, Dr. Patterson will do postural orthostatic tachycardic syndrome, and hopefully we'll be better at our technology than we were tonight, but you just do the best you can. And we're available if you have any questions. Please feel free to contact us. You can contact us on our website with a contact form or to call us. And that'll be great. Thank you.